बिट्टू क्या हो गया बिट्टू? ये बिट्टुआ कहाँ गया थोड़ा?
Hi guys, welcome back. We shall now be talking about aspects related to heart sounds, which is a very simple and a straightforward topic. But if you are confident about this, you will be able to solve questions in a better fashion. So try to hand draw the first 5 line diagrams with me. In the first diagram, I shall be showing atrial You can see that at the moment the tricuspid valve and the mitral valve is open, so atria will be contributing to filling of blood in the ventricles. Approximately 30% filling of the ventricles occurs in the phase of atrial systole. But once the atrium done the responsibility, the pressure in the atrial chamber will reduce, and therefore the mitral and the tricuspid valves will begin to close. Therefore, you will notice that in the second diagram, I am showing the development of first heart sound where mitral and tricuspid valves are exhibiting a closure. Now the pressure will tend to increase in the ventricles of the patient. However, this pressure will be incapable of opening either the aortic or the pulmonic valve. In this diagram, both aortic and pulmonic valve at the moment are still closed. So you can remember this stage as where no blood is coming in the heart and no blood is going out to the heart as isovolumetric contraction. There will also be a slight bulge of the tricuspid and mitral valves occurring during the phase of IVC because the pressure in the ventricular chamber is increasing. What I have just highlighted before you is first heart sound is present at the end of atrial systole, because you can see in atrial systole, mitral and tricuspid valves are open. The moment the pressure will decrease, at the end of atrial systole, mitral and tricuspid valve closure will be occurring. And what they're doing in the exam is that they're trying to link up physiology with internal medicine issues. So that's why we just have to look at this baseline information. Now the question that I'm putting up before you and was asked also, and the question said, which heart sound is present after S1? Majority of guys simply thought that okay, after S1 is obviously going to be S2. But please appreciate that he was asking you a concept from physiology, which is the fact that when the pressure in the ventricles will increase dramatically, I'll just put a bigger plus to highlight that the pressure in the ventricles is even higher now. So this higher pressure will cause opening of the aortic and the pulmonic valves, and therefore ATML blood will rush into the aorta, ATML blood into the pulmonary artery. The amount of blood going in both sides is precisely equal. Both ventricles fire at the same time. Why that is important? Because we will talk about conditions like bundle branch valve, where left ventricle, right ventricle do not fire at the same time, and due to lack of coordination, they can be pulmonary edema or pooling of blood in the lungs. So the amount of blood should go out to be equal, and the firing should occur at the same time. This diagram that I've shown here before you is represented as ventricular systole. And the heart sound that have been highlighted at this particular point of time is called as ejection click, which occurs right after S1 and is called as aortic and pulmonic valve opening. Please appreciate that loud ejection click is a totally separate aspect. But at the moment we're talking about routine ejection click. Routine ejection click is aortic and pulmonic valve opening. So in the exam, if they ask you what is heard after S1, don't answer S2, rather answer it as ejection click, because all they are asking you is the sequence of cardiac cycle. They just want to know, do you know the cardiac cycle sequence? So it is ejection click, and then subsequently, what's going to happen next in the fourth diagram in the series will be that the pressure of the ventricles will begin to fall. If you compare the fourth diagram, previous one, I am now showing that the bulge of the mitral and tricuspid valves will also disappear because blood has gone out into the aorta and pulmonary artery, so pressure is dissipated. The valves have come back to the normal position. At the same compared to the previous into the ventricles of the patient, and at that point of time, on this particular movement, when the blood rushes into the ventricles, at that point, when the mitral and the tricuspid valve is opening, the sound that is produced is technically called as opening snap. Please appreciate that loud opening snap is a feature of mitral stenosis that we will discuss separately. At the moment, I just want you to understand which heart sound is present after S2. Don't answer S3. Your answer is opening snap. We are studying simply the cardiac sequence, and that is after second heart sound we have is an opening snap, which is mitral and tricuspid valve open. The blood will now rush into the ventricles. Approximately 30% of filling of blood occurs in the phase of atrial systole, and the remaining 70% filling occurs in the phase of rapid ventricular filling. So you can see that maximum filling of blood occurs in the phase of diastole, and why that is important for you to know is because if the heart will beat very, very fast, then it will not be getting sufficient time to relax. If the heart will not relax properly, it will not get filled with blood, and if input is less, output will also be less. So the importance of understanding this hemodynamics or the sequence of events that I've just explained to you here is that first you hear a S1, then you hear an ejection quick, then a second heart sound, then an opening snap in a patient. So whenever you are going to auscultate your patients, so therefore the sequence that is to be remembered by you is like this. This is the lumped up heart sounds that we are able to auscultate, that is S1, S2 and S1. Period between S1 and S2 is called as systole. Why? Because right after S1 I taught you there is an ejection quick. If you focus on the English word ejection, it means blood is going out of the heart. Period between S1 and S2 is referred to as systole. The remaining part would be called as diastole, and right after S2 you have is an opening snap occurring in the patient. It represents mitral and tricuspid valve opening because now the blood will be rushing into the ventricles of the patient. I want you to understand that the heart sounds that are shown before you in color blue, they are all high pitch heart sounds. To hear them, you will have to use the bigger side of the stethoscope, that is the diaphragm. However, the ones that I'm showing you now is the third heart sound and the fourth heart sound. These are low pitch heart sounds. They are heard with the smaller side of the stethoscope, that would be referred to as the bell. From this description, you can also solve a question which heart sound is present right before S1, that would be fourth heart sound in the patient. Please appreciate that the question was asked like this. He said, which of the following is a pre-systolic heart sound? He first wanted to see that are you aware what is systole, that is S1, S2? And once you know systole is S1, S2, systole starts with S1, the question was basically which of the following is a pre-systolic heart sound? That will be answered by you as fourth heart sound. I agree to the fact that normal physiology we have S1, S2, S1, that's the sequence, but in the exam he's asking you the sequence with respect to the cardiac cycles, so you anyway have to get used to it. The period between S2 opening snap, this period is called as IVR, isovolumetric relaxation. Then the heart will start getting filled with blood. So in sync with physiology, we will call this phase of rapid ventricular filling. Maximum filling of blood in the heart occurs in the phase of rapid ventricular filling. Say, this is the time when the heart will be having least motor activity. And the remaining part that I have highlighted in color yellow, this is the time of atrial systole. Atrial systole, as you can see, is the time when fourth heart sound is occurring in the patient, which explains the fact that why is it written in the textbook that fourth heart sound is called as atrial gallop rhythm. I will explain to you as we progress in the discussion what are the causes for development of fourth heart sound, but at the moment I just want you to understand that excessive force generated by the left atrium, which is called as or is called atrial gallop rhythm, can be heard in the phase of atrial systole, whereas when it comes to third heart sound, that is heard in the phase of rapid ventricular filling, especially during turbulence. The alternative name for third heart sound is called as ventricular gallop rhythm, especially in patients who are having heart failure because the heart is trying to beat very fast, there's turbulence, the heart is trying to clear the pulmonary edema component. That is why we can hear third heart sound, especially in patients of congestive heart failure. So once you get this basic sequence right, I mean, this is what is to be imprinted in your brain, the sequence that you should be aware of, that first there is this basic infrastructure. The additional aspect that I will explain to you can be understood with this following diagram. I am here showing a benign tumor in the heart. You're all aware that the commonest tumor of the heart is metastasis. That's going to be basically from lung cancer, or it could be breast cancer metastasizing. But we will now discuss a benign tumor of the heart, that is atrial myxoma. It is a pedunculated tumor. What I mean by pedunculated is it will have a stalk. So this is a pedunculated tumor. It has a stalk. It is freely floating in the lumen of the left atrium. It has a stalk by which it is suspended, freely floating in the left atria, and in a way effectively blocking the inflow of blood towards the mitral valve. Therefore, when the blood enters into the heart during the phase of rapid ventricular filling, you can see on the right hand side it can enter very straightforward, very easily, because there is no mass effect, there is no tumor present. But on the left side, when the blood will enter like this, it will strike this tumor, which will cause this tumor to swing like a pendulum. I'm now showing in the same diagram that due to the blood auscultatory finding, which is of interest to me, and that is called as tumor plug sound. The topic that we are studying right now is called as atrial myxoma. The highlight of this topic is the auscultatory finding of the tumor plug sound. It is created, why? Because the tumor goes and hits an open mitral valve. In fact, if the tumor is becoming bigger, like let me say the tumor size has become relatively bigger, it might be as small as a pebble that becomes bigger like a golf ball. So imagine a tumor as big as a golf ball, or the tumor is exhibiting a mass effect. Like if this tumor is relatively bigger, then you can see that it will also limit the inflow of blood in the mitral valve. The inflow of blood into the heart of the patient is substantially reduced. If less would go in, less would come out also. Atrial myxoma is the most common benign tumor of the heart. The auscultatory finding that I brought in here is called as tumor plug sound. The sound is created when the tumor goes and hits. And do remember these words that I say. The tumor hits an already open valve. When I'm saying already open valve, that means the heart is already beginning to relax, because I told you the filling of blood occurs in the phase of diastole, especially rapid ventricular filling. So the tumor hits an already open mitral valve. Why that is important for you to know that already the mitral valve is open, because opening of the mitral valve is called as opening snap. So the sound that is called as tumor plug sound will be heard after the opening snap. I repeat that again. First the valve will open, then the tumor will come and occur after the opening snap in the patient. Let's make it a little more clinical, because nowadays the focus is on clinical discussions. So he will mostly begin by describing a young female. He will say that this young lady, she's having complaints of effort intolerance. She says that earlier I could climb the stairs of my house 10 times per day. Now going up and down even once is a Herculean task for me. So she says that I get tired very soon. And initially I might think that she's having anemia, or she's having some nutritional deficiency, because of which she's not able to do any physical activity. And in this patient, I'm not realizing at the moment that the reason for the effort intolerance is less blood coming in the left ventricle because of the obstruction which is caused by the mitral valve leaflets in the patient. So initially I might prescribe iron supplements, etc., but the symptoms of her are not relieved. In the next consultation, when she came back to me after 15 days, 20 days, or maybe 1 month, the tumor will obviously increase in size, and there's a possibility the tumor might be causing substantial amount of physical obstruction present here to cause congestion in the left atrium. This congestion in the left atrium will cause congestion in the pulmonary venous circuit. So I've just modified the diagram to show the congestion is occurring in the pulmonary venous circuit. This will also result in development of congestion in the lung circuit of the patient, that will translate into development of pulmonary edema. This lady, who was earlier telling me that she gets tired very soon, now is also telling me a very peculiar finding. She says, I also get breathless, and the severity of breathlessness is also increasing. Earlier, it's a possibility that the breathlessness was coming only on climbing. She is seeking my medical advice today. What she will be the next words in the question of the words that this person will say. Position. Why? I repeat again. When the person is setting up like I am at the moment before you, due to gravity, the tumor will go and physically obstruct the opening or the inlet of the mitral valve. But if I'm lying supine, then the effect of gravity is cancelled, and therefore the pressure or the obstruction is relieved. This is an answer to this question. So in case you have come across a question like this, which uses this technical term platipnea, meaning of the word platipnea is breathlessness of the patient is increased in sitting position. Why this is important for you is because simply that in cardiology we tend to focus on the word orthopnea, which is breathlessness in supine position. Orthopnea is what you get in a routine case of acute congestive heart failure. But here we're not talking about congestive heart failure, we're rather talking about a tumor physically blocking the inlet of the mitral valve. Therefore, platipnea is a very good way to solve this question. Now, listening to her history, including this platipnea complaint, I have decided to examine her. On auscultation in this patient, one of the very characteristic finding that is heard and has been told to you already is called as tumor club sound. I want you to remember the tumor club sound is a low pitch heart sound. Because it is a low pitch heart sound, therefore, this can be heard only with the smaller side of the stethoscope, which I explained to you is the well. Based on this, I want to highlight the fact that there are only 3 low pitch heart sounds primarily. The 3 low pitch heart sounds are, and I have explained to you 2 on my previous slide and 1 I have just explained to you, so I will write it down for your convenience. 3rd heart sound, 4th heart sound, and tumor club sound are low pitch heart sounds. Apart from these, all others, whether I say it or I don't say it, it is implied that they are high pitch heart sounds. I repeat my statement. There are 3 low pitch heart sounds in auscultation with respect to heart sounds. 3rd heart sound, 4th heart sound, and tumor club sound are the ones which are going to be heard with the smaller side of the stent. All other heart sounds are going to be implied high pitch heart sounds, and here I've done a color coding also to highlight that the ones in blue are high pitch, that is diaphragm, and the ones in red is the bell. And the new thing that I've added is tumor club sound. I hope you are remembering that tumor club sound will be heard right after the opening snap. Why after the opening snap? Because first the valve should open, at the same time the tumor is showing a downward movement, so it comes and hits, and that is when you could be having this manifestation of tumor club sound occurring in a patient. In fact, lots of time, a lot of doctors might even misdiagnose this patient as that of mitral stenosis. Though this person, because one of the common causes of mitral stenosis, especially in India, is rheumatic heart disease. Why? Because in these patients, the opening is becoming relatively smaller, secondary to the tumor which is obstructing most of the blood. There can be turbulence at the level of the mitral valve inlet. I repeat my statement, I'll just zoom it in so that I can highlight that part again. What I'm saying is that in this person, as the tumor will come down towards the mitral valve leaflet, it is literally behaving like mitral stenosis. You all know the concept of physics that if the opening is small, if liquid goes through a narrow opening, it produces turbulence. So there is a possibility that in this patient, you might be able to hear a mid or a late diastolic murmur also. Mid to late diastolic murmur, why I'm saying this is primarily because of the fact that it will start behaving like mitral stenosis only. The inlet of the mitral valve is becoming relatively small because there's a massive tumor that is coming from the top, so it is reducing the inflow into the valve per se. It is reducing the volume of blood, but at the same time, when the opening is small, there is a increase in turbulence also. So a mid to a late diastolic murmur, lung auscultation, there can be crepitations. These crepitations initially might be heard over the lung basis only. So initially he might say basal crepitations, but as the disease will progress, then you could be having crepitations in both the lung fields of the patient. I have here written bilateral fine crepitations / crackles. Those are like if you open a Velcro tape, the sound that is produced when you open a Velcro tape would be called as crepitations or crackles, and this would be a finding suggestive of pulmonary edema. The investigational choice for diagnosis of this condition is echocardiography. Now, should I do a transthoracic or should I do a transesophageal echo? Then do remember that for ventricular side, it is transthoracic, which is relatively better, but to identify something that is in the atria, because in this diagram is a two-dimensional diagram, atria are rather posteriorly situated. So transesophageal echo is superior for especially identifying atrial pathology. Once I know it is a tumor, then I have to plan surgery for this patient because as such, there is no medical treatment for this particular case. To relieve the pulmonary edema component, I can obviously give diuretics to the patient initially so that the person is relatively better, but I will anyway have to refer this patient to the Department of Cardiothoracic Vascular Surgery, where a surgical resection of this person's tumor will be done, and that's the only cure that we can give to this person. And if the surgery is done on time, then I would say that the prognosis of this condition is excellent. Obviously, the tumor starts causing substantial amount of obstruction. Now, the tumor causes embolic effects because you see when the tumor mass keeps on expanding, the cancer cells that can embolize from here contribute to even transient ischemic attack kind of a manifestation in a person. So do not be surprised if in the same MCQ they might give you a TIA attack manifestation. TIA is transient ischemic attack. The neurological symptoms of like sudden onset aphasia or maybe a weakness in one hand lasting for a few seconds to few minutes, maybe up to half an hour, could be given in this question just to make you think that this question is related to something from neurology. But I want to just tell you that a neurological complication of this condition is embolism that could occur secondary to a tumor which is present. It could be cancer cells. Cancer can contribute to thrombus formation because after the tumor is causing obstruction in the left atria, so there could be stasis, there could be clot formation in the left atria, and that can embolize into systemic circulation. So transient ischemic attacks could be described in this question. I'm just putting a plus minus here. That's a distraction for you in the question. The clinching point, the main point for you in the question would be the word leukemia. Now, I would like to mention a differential diagnosis of this condition. So look at the next diagram and compare with the previous one. In this case, I'm again showing a tumor which is present in the related to the heart valves only. But if you compare the previous and this diagram, this time I'm showing the tumor originating from the valve reflex. The last time I was showing a tumor originating from the interatrial septum that was going down and obstructing the inlet of the mitral valve. Now you can see a very distinct tumor which is originating from the valve leaflet. This condition or this tumor is itself described as a MCQ or is asked as MCQ. It is called as papillary elastoma. The theory to be remembered by you is differential diagnosis of atrial myxoma is papillary elastoma. This tumor originates not from the interatrial septum, it originates from the valve leaflet. Therefore, what you have to understand is that for this condition, there is nothing like a tumor resection that will be done because this will destroy the valve leaflet. So in this condition, we will have to put in a prosthetic heart valve in the patient. There is no point of going in for any surgical repair. Valvuloplasty will not help in this condition because the tumor, by the time it is diagnosed, it would have destroyed and deformed the valve leaflet. A deformed valve leaflet cannot coapt like normal. Therefore, there could be even MR manifestation, mitral regurgitation manifestation in the patient. This condition is a differential diagnosis of atrial myxoma called as papillary elastoma.